morning. Today's topic of discussion is cyst. Cyst is derived from a Greek word cytis, which means bladder or sac-like lesion. The definition goes like this. As Kramer defined it in 1974, a cyst is a pathological cavity having fluid, semi-fluid, gaseous contents and which is not created by the accumulation of pus. It is frequently but not always lined by epithelium. There are two types of cyst, that is a true cyst and a pseudocyst. True cyst is lined by epithelium. Pseudocyst is not lined by epithelium. The definition was given by Reichert and Philipson in 2004 and they termed it as cavity. Classification of cyst. Cyst of Johs can be divided into epithelial line cyst and non-epithelial line cyst. The epithelial line cyst can be again divided into developmental and epithelial origin. The developmental origin, again it is classified as odontogenic and non-odontogenic. In odontogenic cyst, there is gingival cyst of infants, gingival cyst of adults, odontogenic keratocyst, dentigerous cyst, eruption cyst, lateral periodontal cyst, butchered odontogenic cyst, glandular odontogenic cyst, and calcifying odontogenic cyst. In non-odontogenic, mid-palatine cyst of infants, nasopalatine cyst, and nasolabial cyst. In inflammatory, so it was mainly divided into developmental and inflammatory. In inflammatory, the radicular, the apical cyst or the lateral cyst, the residual cyst, paradental cyst, juvenile paradental cyst, inflammatory collateral cyst. The main classification, that is epithelial and non-epithelial. In the non-epithelial, it is solitary bone cyst and aneurysmal bone cyst. Cyst associated with the maxillary antrum. It can be mucosal, retention cyst, pseudocyst, post-operative maxillary cyst, and cyst of soft tissue of mouth, face, and neck. It is dermoid and epidermoid cyst, lymphoepithelial cyst, thyroglossal cyst, anterior median lingual cyst, oral cyst with a gastric or intestinal epithelium, cystic hygroma, nasopharyngeal cyst, thymic cyst, and cyst of salivary gland, parasitic cyst. What are odontogenic cysts? A cyst in which the lining of the lumen is derived from epithelium involved in tooth or embryonic development. So going again, a cyst in which the lining of the lumen is derived from epithelium involved in tooth or embryonic development. Epithelium is derived from, it can be either derived from the tooth germ, reduced enamel epithelium, epithelial cell rest of molasses, remnants of dental lamina, basal layer of oral epithelium. What are parts of a cyst? Macroscopically, it is divided as lumen and capsule. So these are the two parts. Lumen, that is the central portion, as you can see in the picture, and the capsule, that is the leathery pouch. Microscopically, it is lumen and epithelial lining the facing lumen and the capsule. So these are the parts of the cyst, macroscopic and microscopic. Cystic fluid origin is either by the secretion, transudation, or osmosis. The cyst consists of cystic fluid, so that is the origin, various origin of the cystic fluid, either by the secretion or transudation or osmosis. What are the contents of the cystic fluid? It is the serum proteins like albumin and globulin, glycoproteins like the glycosaminoglycans, proteoglycans, keratin, lipids, cholesterol crystals, enzymes like proteases and inhibitors, fibrinolysins, and collagenase. The consistency of the cystic fluid either is watery, viscous, semi-solid, or cheese-like. The color, it is either grainy yellow, that is because of the presence of keratin. It can be brownish also by the presence of blood or blood products, or it can be straw colored because of the presence of cholesterol. So as we will go again, that is the cystic fluid. Cyst consists of a cystic fluid, and where does the cystic fluid origin from, and what are the contents and the consistency of the cystic fluid, and what gives the color for the cystic fluid. So that is the generally about the cyst. Clinical significance of a cyst. It is easily mistaken for a tumor because of swelling, bony expansion and asymmetry. There will be pathological fractures involved. It can interfere with the normal function and eruption of the teeth. It can either also cause secondary infection. Secondary infection can cause pain, pus formation, and sinus formation. and it can also lead to neoplasms also, like angioblastoma, mucoepidermal carcinoma, and squamous cell carcinoma. What are the symptoms of a cyst? That is a pain and swelling, there will be salty taste, difficulty in mastication, ill-fitting denture, displaced teeth, and space between the teeth. So if you find a cyst, these are the features which can be seen concomitant with them, but not always all the cysts will show all these symptoms. So if pain and swelling, not always a feature. Salty taste is associated with the nasopharyngeal cyst. Sometimes difficulty in mastication also can be noted, ill-fitting denture, and the displaced teeth, the space between the teeth. These are the symptoms which you see. What are the signs of a cyst? So when there is a cyst, you can find all these signs also. There will be expansion of the bone and fluctuant swelling under the oral mucosa. And usually it will be associated with a non-vital tooth. And sometimes a missing tooth also will be seen. Sinus formation with a discharge and hollow sound on percussion. So these are the signs and symptoms associated with the cyst. What are the clinical stages of a cyst? Periosteal stimulation, tennis ball-like consistency, eggshell crackling, fluctuation, sinus formation if there is infection with the contamination from the oral cavity. So going to each one, periosteal stimulation, that is a curved enlargement of the bone. Tennis ball-like consistency can be indented on percussion. Eggshell crackling also can be indented by percussion. Can be micro cracks on the cortical bone will be noted. Fluctuation, that is complete resorption of the bone over the overlying the cyst. If there is an infection due to contamination from the oral cavity, you can see the sinus formation. So these are the clinical stages of a cyst. Now, how do a cyst grow and enlarge? So it will start with the process of initiation, then there is a proliferation, then there is cystification, and then it is enlargement. So these are the various stages. It goes to the initiation, proliferation, cystification, and then the enlargement of the cyst. What are the phases of cyst formation? There are two main concepts. So Summers in 1974, he gave this concept as epithelium proliferates and covers the connective tissue surface of an axis cavity, or cavity is a result of the connective tissue breakdown by the proteolytic enzymatic activity. So that is what you see in a radicular cyst. As Summers came in 1974, epithelium proliferates and covers the connective tissue surface of an axis cavity, or cavity is a result of the connective tissue breakdown by the proteolytic enzymatic activity. The second concept is that the cyst cavity forms within the proliferating epithelial mass by degeneration and death of cells in the center. So among these two concepts, the second one is the most accepted. That is, the cystic cavity forms within the proliferating epithelial mass by the degeneration and death of the cells, that is lysis of the central cells. That is how the cyst is formed. That is the most accepted theory. Now we can classify the cyst by the tissue of origin. So as we said, it is an ontogenic epithelium, and the ontogenic epithelium is derived from the cell rest of molasses. It will be reduced from epithelium, enamel organ. Okay. So according to the derivative, the tissue of origin, again we are dividing it into derived from the epithelial cells of molasses, that is periapical cyst and residual cyst, and derived from the reduced enamel epithelium, that is dentigerous cyst and eruption cyst. So epithelial cell of molasses is derived from they are the remnants, cell remnants of the Hertz epithelial root. So those remnants are called as epithelial rest of molasses. So epithelial rest of molasses is seen in the periodontal ligament. So two cysts derived from that is your periapical cyst and residual cyst, and derived from the reduced enamel epithelium, that is the epithelium that covers the newly formed enamel. So that is the dentigerous cyst and eruption cyst. Derived from the dental lamina. So maximum number of cysts is derived from the dental lamina rest. So the remnants of dental lamina is called as the cell rest of the serous. So the cysts which is derived from these are ontogenic keratocysts, otherwise opaque, gingival cyst of newborn, gingival cyst of adult, lateral periodontal cyst, and glandular epithelial cyst. And the two are unclassified into any of the epithelial derivatives, that is calcified epithelial cyst and parodontal cyst. So that is the classification of the cyst according to the where the tissue where it derived. So coming to the first cyst, that is a dentigerous cyst. Dentigerous cyst, the definition goes like this. Dentigerous cyst is defined as an odontogenic cyst that surrounds the crown of an impacted tooth caused by the fluid accumulation between the radius epithelium and enamel surface, resulting in a cyst in which the crown is located in the yolk. So we'll go again. Dentigerous cyst is defined as an odontogenic cyst that surrounds the crown of an impacted tooth caused by fluid accumulation between the radius epithelium and enamel surface, and resulting in a cyst in which the crown is located in the yolk. So earlier term of dentigerous cyst is follicular cyst. Brown and Smith in 1991 termed it as dentigerous cyst. So previously it was called as follicular cyst, and it was Brown and Smith who changed the name into dentigerous cyst. The term dentigerous means that tooth bearing. So this cyst is a tooth, contains tooth within that. What are the macroscopic gross features of dentigerous cyst? The dentigerous cyst, as you can see in the picture, the cystic lining, the cyst is attached to the tooth at the CEJ, the cemento-enamel junction. In the both pictures, you can clearly identify the attachment of the cyst to the capsule into the CEJ, What are the clinical features of a dentigerous cyst? It is associated with the crown of impacted, embedded or unerected tooth, also found enclosing the complex compound odontome or supernumerary tooth. So any impacted or embedded or unerected tooth, you can see this cyst is enclosing any of the tooth. It could be a unerected or impacted tooth or a supernumerary tooth, or it could be a odontome also. All the cases it is impacted. Most common odontogenic cyst. So it is the most common odontogenic developmental odontogenic cyst, 20% of the case. As we all know, the most common cyst is radicular cyst, and most common odontogenic cyst is dentigerous cyst. The common occurrence is second and third decade of life, commonly seen in males with a 1.6% to a ratio of 1 in females. The most common site of occurrence is mandibular third molar region. So in prevalence of occurrence, mandibular third molar, maxillary canine, mandibular premolar, and maxillary third molar. There are chances of all these two is impacted. So the chances of occurrence is in the mandibular third molar most commonly. Then the second is maxillary canine, then mandibular premolar, and then the maxillary third molar. It is usually seen as a solitary swelling. Bilateral and multiple cysts are also found. So if you see bilateral and multiple cysts, then you should find the association of any syndromes. Here you could find a syndromes associated. It could be the cleidocranial dysplasia or Matt-Slamy syndrome. So you should be diagnosis should be proper. Potentially capable of becoming aggressive. So expansion of bone leads to facial asymmetry. In some cases, there will be displacement of teeth also is noted. The root resorption of the adjacent teeth also is noted. Pain if it is secondary infected. Cystic involvement of an unerected mandibular third molar may cause hollowing out of the entire ramus, extending up to the coronal process and condyle. There may be displacement of the third molar to such an extent that it sometimes comes to lie compressed against the inferior border of the mandible. So, if there is a cyst associated with the mandibular third molar, the entire ramus can be hollowing out of the entire ramus also, extending up to coronal process and condyle. So that extensive the lesion can be. Okay, and displacement of the teeth, that is a feature of the dentigerous cyst. The displacement can be to such an extent that it can lie compressed against the inferior border of the mandible. Coming to the pathogenesis of dentigerous cyst. There are two theories to explain the pathogenesis: extrafollicular theory and intrafollicular theory. Extrafollicular theory, tooth erupting into the pre-existing cystic space. It is not well accepted. That is usually seen in the deciduous tooth. So the tooth may erupt, the permanent tooth erupting into a cystic space, which is the cyst which is formed in associated with the association with the primary tooth. So that is one theory. Second is intrafollicular theory, that is accumulation of the fluid between the radicular epithelium and enamel. So that is one, or within the enamel organ, that is accumulation of the fluid between the radicular epithelium and enamel, or layers of the radicular epithelium. So intrafollicular theory, there are two concepts, and the intrafollicular theory is most accepted than the extrafollicular theory. How you differentiate between a dilated follicle versus a dentigerous cyst? So a follicle also is seen around the erupting tooth. So the normal follicular space is 3 to 4 mm, but in case of a dentigerous cyst, it is more than 5 mm. So radiographically, if you see a lucency, that is more than 5 mm, then you should be suspicious of a dentigerous cyst. So that is how you differentiate between a dentigerous cyst and a normal follicular space. Radiological features. A well-demarcated unilocular radiolucency, that is a feature associated with crown of an unerupted tooth. So yeah, impacted tooth. So that is a peculiarity in the radiographic appearance of a dentigerous cyst. So this will have a well-defined sclerotic margin unless they become infected. So a unilocular radiolucency associated with an unerupted tooth, and the radiolucency will have a sclerotic border. Occasional trabeculations may be seen and give an erroneous impression of multilocularity. So again, trabeculations also can be seen. Coming to the radiological variants, there is a central variant, there is a lateral and circumferential. So these are the pictures which actually shows the central, lateral and the circumferential radiographic variants of your dentigerous cyst. So this is a radiograph which shows the central variety, lateral variety and the circumferential variety in that order. Coming to the first one, that is your central variety. Crown is enveloped symmetrically. When the pressure is applied to the crown of the tooth and may push it away from the direction of eruption. So the central variety, when the tooth starts to erupt, the pressure will be applied onto the crown of the tooth, and this pressure can push away the tooth from its direction of eruption. So mandibular third molar may be found at the lower border of the mandible or in the ascending nares. Since we are talking about mandibular third molar because that is the most commonly impacted tooth which is found, and dentigerous cyst is mostly associated with the mandibular third molar. Maxillary canine may be forced into the maxillary sinus. So that is the first variety in the radiographic appearance, that is the central variety. So usually you see a unilocular radiolucency, but according to the appearance, it can be central, lateral and circumferential. Lateral variety. It is a radiographic appearance that results from the dilatation of the follicle in one aspect of the crown. This type is commonly seen when an impacted third molar is partially erupted so that its superior aspect is exposed. Circumferential variety, the right tooth appear to be enveloped by the cyst. This variety should be differentiated from the envelopmental type of aplasia. Coming to the histopathological features of dentigerous cyst, a thin fibrous cyst wall derived from the dental follicle consists of M fibroblast. It is widely separated by stroma and ground substance, rich in glycosaminoglycans. So you can see a cystic wall that is derived from the dental follicle. So since it is derived from the dental follicle, you can see M fibroblast. This will be widely separated by the ground substance. Now, the important part of a cyst, that is epithelial lining, that is an intact reduced epithelium. So as we said, the derivative of your dentigerous cyst is from the reduced epithelium. So it consists of 2 to 4 cell layers of flat or pure burden cells, which is non-characterized. The epithelium and the connective tissue interface is flat. So that is the histopathological features of the dentigerous cyst. A thin fibrous cystic wall derived from the dental follicle consists of M fibroblast, and it is separated by stroma and ground substance. The epithelial lining is intact, reduced epithelium with the 3 to 4 layers of flat or pure burden cells. The epithelium and the connective tissue interface is flat. Thicker connective tissue wall, very loose fibrous connective tissue or myxomatous connective tissue also is known. Varying number of islands of odontogenic epithelium is not an important issue. Some cases, if it is separately infected, you cannot find the inflammatory changes also. Pluripotent epithelium. So sometimes there will be metaplasia of mucous cells, respiratory lining, and even lymphoid follicles also can be noted. There are potential complications for the dentary cyst. So ambroblastoma from cystic lining or odontogenic rest, nodular or mural thickening also can be noted. So here the Meeker recording criteria has to be taken into consideration. So usually the cystic epithelium of the dentary cyst can transform into an ambroblastoma. Second, it can be to squamous cell carcinoma, that is keratin metaplasia in long-standing cyst, and mucous metaplasia, that is mucoepidermal carcinoma. Treatment: smaller lesions can be surgically removed with legibility. The larger cysts are often treated by insertion of the surgical drain or marsupialization. So that is the treatment of the dentigerous cyst. The next cyst, that is eruption cyst. Eruption cyst is defined as an odontogenic cyst with histological features of dentigerous cyst that surrounds a tooth crown that has erupted through bone but not soft tissue and is visible clinically as a soft fluctuant mass on the alveolar ridge. So the definition goes like this: eruption cyst is defined as an odontogenic cyst with histological features of the dentigerous cyst that surrounds a tooth crown that is erupted through the bone but not soft tissue and is visible clinically as a soft fluctuant mass on the alveolar ridge. Eruption cyst is a dentigerous cyst occurring in soft tissues as given by Shear in 1992. Pathogenesis of an eruption cyst. It is similar to that of a dentigerous cyst. Eruption cyst is embedded in the soft tissue of gingiva rather than bone. The presence of dense fibrous tissue in the overlying gingiva may be responsible for the eruption cyst. So, as we said earlier, it is similar to that of a dentigerous cyst. Eruption cyst is embedded in the soft tissue of gingiva rather than the bone. So, presence of a dense fibrous tissue that prevents the eruption of the tooth, that will lead to the presence of eruption cyst. Clinical features: it is a frequency rate is 0.8% of cases, mainly in children and occasionally in adults also. Deciduous and permanent teeth involved frequently anterior to the permanent molar. So usually it involves anterior to and mainly the central incisor. Appears as a fluctuant translucent swelling of the alveolar ridge over the site of the erupting tooth. And that is the clinical appearance of the eruption cyst. When circumoral cystic cavity contains blood and the swelling appears purple or deep blue, then it is called as eruption hematoma. So when the tooth tries to erupt and it contains blood in, that is the picture showing the eruption hematoma. It is painless unless it is infected. Coming to the histopathology, the superficial aspect is covered by keratinized squamous epithelium of the overlying gingiva. This is separated from the cyst by a strip of dense connective tissue of varying thickness that has mild chronic inflammatory infiltrate. The gingival connective tissue is relatively cellular and densely collagenous, so has the eosinophilic hue. Odontogenic epithelial islands also may be present in the connective tissue. Epithelial lining of the cyst is characteristically of the reduced epithelial origin. So it consists of 2 to 3 layers of cell thickness. The adjacent corium is hyperemic and has a chronic inflammatory infiltrate. So these are the features of the eruption cyst. Coming to the radiographic features, the cyst may throw a soft tissue shadow, but there is usually no bone involvement except that the dilated and open crypt may be seen on the radiograph. Treatment: treatment is necessary as the crypt ruptures spontaneously. If there is a difficulty in the eruption, then you can go for a surgical exposure of the crown of the tooth. So this will aid in the eruption of the tooth. So that is about the eruption cyst. Similar to that of the dentigerous cyst. The dentigerous cyst is central and eruption cyst is a soft tissue cyst. Next one is gingival cyst of infants. So it is also called as dental lamina cyst of newborn, since it is derived from the dental lamina. Multiple occasionally solitary superficial raised nodules on edentulous alveolar ridges of infants derived from dental lamina that resolve without any treatment. So that is the definition. Multiple, occasionally solitary, superficially raised nodules on edentulous alveolar ridges of infants derived from dental lamina that resolve without any treatment. They are derived from the dental laminaris and contain keratin-producing lining. There are two similar entities, that is Epstein's pearls and Bond's nodules. Epstein's pearls, that is, it is cystic keratin-filled nodules at the mid-palatal raphe. It is non-odontogenic. And Bond's nodules, they are keratin-filled cysts scattered over the palate, mostly at the junction of the hard and soft palate. They arise from the minor salivary glands. So they are developmental nodules. So there are two similar entities similar to that of your gingival cyst of newborn, that are Epstein's pearls and Bond's nodules. So Epstein's pearls are seen in the mid-palatal raphe, and Bond's nodules are seen scattered on the palate. So one is non-odontogenic and one is developmental. So that is the cyst seen Epstein's pearls here at the mid-palatal raphe. Picture shows the presence of Epstein's pearls, and these are the Bond's nodules that you see on the alveolar ridge. So cystic clinical features, a small discrete white swellings on the alveolar ridge. So that is how it appears, and they are asymptomatic. Histology: very thin epithelium, lacking arrhythmic ridges. Lumen is filled with discriminated keratin. Occasionally, you can find some inflammation cells. Even dystrophic calcification also is seen rarely. Presence of hyaline bodies or Rushton bodies. So inflammatory cyst usually shows hyaline bodies or Rushton bodies. These are arc-like bodies that is seen on the epithelium. So that is histology. Now coming to the difference between Bond's nodules and Epstein's pearls. Bond's nodules are keratin-filled cysts scattered over the palate, mostly along the junction of hard and soft palate. And they are derived from the palatal salivary gland structures. Epstein's pearls, they are keratin-filled nodules along the mid-palatal raphe. And the Epstein's pearls are derived from the epithelial remnants along the line of fusion. So Bond's nodules are keratin, both are keratin-filled nodules. But Bond's nodules are scattered over the palate along the junction of the hard and soft palate. But Epstein's pearls are seen along the mid-palatal raphe. So Bond's nodules are derived from the palatal salivary gland structures, and Epstein's pearls are derived from the epithelial remnants along the line of fusion. Epstein's pearls are non-odontogenic, and Bond's nodules are developmental in origin. Bond's nodules and Epstein's pearls, there is no treatment required for this, will appear by opening onto the surface of mucosa. So there is no treatment required, and they will disappear by opening onto the surface of the mucosa through disruption of the eruptive teeth. So these are the three cysts which we dealt with today. So cyst, what is a cyst, and the definition given by the Kramer, and dentigerous cyst, eruption cyst, and the cyst of a newborn in detail. So that is today's lecture. Thank you for being attentive. Thank you for your patience.